All right, guys, welcome to the next session. It's 4 a.m. Eastern time. We are getting the wee hours of the morning here on the East Coast, and so many of our surgeons are starting to wake up. But Amanda's been up for a while. Amanda's going to be our next moderator. Take it away, Amanda.
Great. Thank you so much. I think if nothing motivates you to get up at 4 a.m. like a talk on ankle arthritis, then you're really, really missing out. So today I have a couple of my colleagues and friends with me to help deliver this 4 a.m. lecture. The first is Dr. Megan Wolf. She also practices in Connecticut. She also thought 2 fellowships was a good idea and was actually UConn's first foot and ankle fellow, having been a graduate of the UConn orthopedics program, been in practice for a little bit and came back. She has now started practice all over again because once wasn't good enough for her. Dr. Shannon Alejandro is a delightfully incredible human who was a fellow, I think, 2 years after me in Dallas. She is amazing and has recently moved from Asheville back to Dallas and is part of the Baylor Foot and Ankle program there. She too could come to Connecticut if only we could convince her she likes the snow. So these are my partners for the next 58.5 minutes. And we're going to start initially with Dr. Wolf talking about some non-operative management, Dr. Alejandro talking about ankle arthritis, and then I'm going to talk about some recent biologic studies about ankle arthritis. Feel free to ask any questions. We are here, and I will be following the chat as well.
All right. So this is talking about non-operative treatment of ankle arthritis. Not a lot out there in the literature. It's really mostly just discussion based on experience, not a lot of data regarding this. But when we're talking about treatment goals for arthritis, we're going to talk about any treatment for non-operative or operative treatment. These should be our goals. So you want a painless foot, an ankle that's stable, that's plantigrade, and that's shoeable. And those should be our goals, whether it's non-operative or operative. You can go to the next slide. So again, treatment goals are pain relief, deformity correction, prevention of progression, and then from a function standpoint, to have preservation of function, and then potentially restoration of function if there's functional deficits. You can go to the next slide. Oh, Google Slides reformatted all of my slides. Sorry. So the treatment options include medications. So the first kind of foremost thing that we think of when we're talking about any arthritis medications is anti-inflammatories. So NSAIDs. This can be oral or topical. I tend to use both. I think topical anti-inflammatories are pretty effective in the foot and ankle just because of its location directly below the skin, even in our larger patients. However, the response to both are varied. It can have side effects. So people who have reflux have a tough time with anti-inflammatories. And it's not a long-term solution. There can be long-term side effects for anti-inflammatories. And so that's not something that they can be on for years and years and years. Another option is oral steroids. This I tend to use and as a first line for my patients who can't take anti-inflammatories. It also can be helpful for people who are on anti-inflammatories for a longer period of time. Tylenol is another option from a pain relieving standpoint. However, it doesn't have an effect on the inflammation. And then supplements, really not a lot of great data. There's a lot of subjective information saying that it's beneficial to pain improvement, but the studies haven't really demonstrated that there's any efficacy for this. You can go to the next slide. So in terms of injections, corticosteroid injections are the first line. Pain relief. Really, most of the data that we have for ankle arthritis is interpreted based on our knee data, which demonstrates significant pain relief, however, short term. I find that what I've seen in the literature is that the short term is actually less than what we typically see with knee arthritis. However, it is a good first line and it does show efficacy. Viscosupplementation is not currently FDA approved for the ankle, and really has been a source of difficulty from a practitioner standpoint due to insurance not really covering it, and it can get pretty expensive if patients are trying to use this with cash options. However, the data really shows more intermediate AOFAS score improvement, but any head-to-head studies have really shown that saline, it's no better than saline. And so this is why insurance has been giving us a difficult time, and FDA has really not been supporting ankle arthritis for viscous supplementation. Next option. So activity modifications, this is another mainstay of treatment for ankle arthritis. So patients who come in, especially patients who have had unstable ankles and then develop arthritis, tend to be a really high activity patient. So some options is to modify or terminate vigorous activities. This is like our high intensity interval training, and really high, lots of jumping and high impact, including marathon runners, etc. And so really the recommendation is to do low impact activities. This can include the elliptical, the bike, and then also our labor jobs really have a difficult time with managing arthritis. And so if they can change to a more sedentary job, this can help with decreasing pain and increasing function. Physical therapy has really been shown to be beneficial in the knee literature. However, not a ton of data in the foot and ankle literature on physical therapy. Especially for patients who have a lot of instability, it can really help with strengthening the muscles surrounding it, or allow to help with gait training once they've obtained any bracing or orthotics. And weight loss is really important, so it can decrease the reactive forces throughout the joint and improve the effectiveness of conservative and operative options. And so that's definitely something to discuss right from the very beginning, because that can be a long journey for patients. Here at the next slide. So assistive devices can be helpful. So a cane, using the cane in the opposite hand from the painful foot and ankle, you can mechanically unload that joint, and it can also help with stability. You can have prefabricated options. So these are some options that we can provide our patients on the first day that we're seeing them, that can be over-the-counter orthotics, ankle braces. Initially, with significant pain, you can consider a cam boot or a walking cast to try to decrease their pain until they're able to obtain a more functional orthotic or brace. Another option is there are over-the-counter carbon fiber non-articulating AFOs that can be an option. And this is best suited for patients who are compliant with regular wear. Really, these AFOs and these braces only work if the patients wear them. So if they're not wearing them, that's my first question that I ask them, then they can continue to have significant pain. Next slide. Now, custom orthosis, this is probably our mainstay, our next mainstay treatment for patients with ankle arthritis. However, not all insurances cover them, and it can be pretty pricey. So if there's flexible hindfoot deformity that's leading to pain and instability, if that patient is able to correct their hindfoot, then a semi-rigid functional orthotic may be helpful for this. This can be considered for our pes plana valgus patients with UCBLs and SMOs to control or restrict hindfoot motion and allow for correction of that deformity. AFOs can be helpful. This can be solid or hinged. I find that patients who have significant instability of their ankle tend to not do super well with hinged AFOs and tend to do a little bit better with solid, but that's been my experience. Arizona braces, this can be either in a lace-up form or a Velcro form. And that's really, again, for unstable joints and axial malalignment. And then patellar tendon-bearing orthotics to unload the foot and ankle. So even with any of these orthotics and braces, really the axial forces are still there, and that can lead to significant pain and dysfunction. And so the patellar tendon-bearing orthotic, which is kind of difficult for some patients to use, especially our larger patients, the goal of that is to take away some of those axial forces that can cause pain. Next slide. So a little bit more about AFOs. It can provide partial pain relief, again, because it can help with deformity correction and can somewhat unload the joint, but it still won't take away the axial load to the joint. You want it molded to the contour of posterior calf muscles. You can have a leather ankle lacer with propylene shell that can fit into a shoe. And then there's also another type of AFL called a calf lacer. However, this requires a metal drop lock that fits to a single shoe. This can somewhat offload the ankle a little bit better. However, people don't tolerate it as well because you can only wear one type of shoe. All right. So, and then finally, shoe wear modifications. So even with any of our orthotics or braces, I always counsel patients to obtain a rocker bottom shoe. It compensates for the loss of ankle range of motion, allows for foot progression whenever they're ambulating. What's really nice is that there are a lot of over-the-counter shoes that now have this option. And so I really tend to send my patients to running stores or footwear specific stores, and they can get over-the-counter rockers. Another option that's more custom is a solid ankle cushion heel, and this can provide hindfoot stability and shock absorption as well. But both of these, the goal is to improve forward progression during the gait and to normalize gait function. And so these are really good, again, to obtain prior to obtaining to doing physical therapy so that they can work on this normalizing gait pattern.
Okay, so before we move on to Dr. Alejandro, thanks, Dr. Wolf. I'm gonna go back a couple slides. So everyone who's on here can answer, including Dr. Prek, if you are available. But I think one of the things that makes bracing really difficult, as you mentioned, is compliance. I don't have a go-to brace because I have a hard time in general getting patients to be compliant. I think women in particular are much less likely to wear a brace, particularly as they're like not wearing pants as frequently, or they might be wearing, a skirt or a dress, and they don't really want to wear their AFO brace or an Arizona brace with shoes that are like 2 sizes too big for it. So I frequently don't even end up doing bracing beyond like an ASO brace, which people still complain about fitting in a shoe, for treatment. But do you have a brace, Dr. Alejandro, Dr. Prek, Dr. Wolf, that you go to that you think like people actually do tolerate this, and it really buys them some time before surgery? And the other consideration for that is that braces are expensive, right? If you want to get a custom Arizona brace made, that could be between $1,000 and $2,000 depending on where you are. Granted, insurance will cover it, but now we're talking about somebody who's braces in the closet.
Yeah, yes. For me, I really, a lot of these patients that I indicate an Arizona brace for, those patients have failed every other thing. They tend to be really frustrated. Those that I indicate for really don't care about their shoe wear as much. I really have gone to the Velcro Arizona braces because most of these patients have a difficult time with upper extremity function, as well as bending over to put this on. And so I really work closely with my orthotist on creating the Velcro Arizona braces. But I do look at that whenever I'm talking to patients about it, and I discuss with them about what it looks like and making sure that they're willing to do it. But I've really found that Arizona braces have been covered by insurance, and I haven't had as much of an issue with getting that specific brace covered.
No, I think they're covered. I just don't think people wear them. I have a hard time.
Sure.
Even when they're covered, the deductible that patients often have to pay is too much for them. I have the same experience, especially with my women. I feel like I can't get them to wear a custom brace, and so I just use an ASO, and we talk about supportive shoe wear. And most patients, in my experience, either solidly just aren't ready and don't want surgery, and so they're going to just do the ASO until they are ready, and then they'll go and have surgery. So I was tasked with epidemiology and prevalence of ankle arthritis. Exciting topic. We'll talk about the prevalence, why ankle arthritis is different than hip and knee, and then different etiologies for getting ankle arthritis. And so the ankle is not the knee. I nerded out a little bit looking at the history of the knee and the ankle. So archaeologists have looked at skeletal remains of ancient humans, and they found that the primitive knee, not even the modern knee, developed almost 2 million years ago. And then the primitive ankle was behind it and didn't develop until about 1.6 million years ago. Looking at skeletal remains, they found very low evidence of ankle arthritis in the skeletal remains, less than 8%. Interesting now because only about 1% of the population has symptomatic ankle arthritis. So it makes you wonder, In primitive man, were they even symptomatic if it was less than 8%?
It's the running, Shannon. It's the running.
I know, I just think it's so neat. And so why is the ankle so much less susceptible to having arthritis than the knee? There's a few different reasons. One is looking at the cartilage itself. The cartilage of the talar dome is much denser than cartilage you see at the knee and at the hip. The cartilage is denser because of all the fun stuff you learn in medical school, molecular biology. So higher proteoglycan and sulfated glycosamine glycan content, there's less water content. And then ankle chondrocytes are interestingly not as susceptible to inflammatory markers like interleukin-1 and multiple others. That was just the most familiar one, so I put that on there. And so this leads to less susceptibility to actually damaging the cartilage itself in a pro-inflammatory state. And then if we look at the mechanical factors of the tibial-talar joint, this joint is highly congruent compared to other joints. Even then, most of the load goes through the talar dome, and so there's a larger load-bearing surface per surface area. And then there's also, with normal activity, a narrow range of motion for that joint. I thought it was interesting that with running, that 5 to 13 times our body weight is transmitted through the ankle, which is much higher than the hip and the knee. So it actually sees more force but has less arthritis. So going to the etiologies, the most common by far when looking at ankle is post-traumatic arthritis. This accounts for about 80% of arthritis in the ankle, much more common than the hip and knee. The interesting thing about this is because ankle arthritis occurs in younger patients, it's a higher burden to society because the impairment, it happens around 10 years earlier than normal arthritis would happen. And this happens when patients would normally be working and being productive to society. Some studies have looked at what comparable impairment, and it compares to end-stage renal disease, congestive heart failure, and then end-stage hip disease. Hip osteoarthritis is on the same level. Oh, this was a video. I don't think it's going to work. It showed how impaired the patient was with, and this is after she had treatment. It's impressive, but I don't think it'll work on the Google Drive. Oh, shame. Anyways, so post-traumatic arthritis, it's most common with ankle sprains, dislocation, and rotational ankle fractures. I think that's really because those are the most common ankle injuries we see rather than pilons. Increased risk factors occur if you have the following. Increased risk of getting arthritis occur if you have the following risk factors during the trauma. And that's smoking, high BMI, and then age over 30. When we're looking at tibial plafond fractures, because the anterior plafond loads more than the posterior plafond, if you have anterior impaction, you're more likely to develop post-traumatic arthritis. And then the higher the energy at the time of the trauma leads to more chondrocyte death. And of course, in a reduction, if it's mal-reduced, you'll get increased joint contact stresses leading to abnormal loading and chondrocyte death. Looking at inflammatory arthritis, this is the next most common cause. We all think of rheumatoid arthritis, but there is a nice rheumatologic paper that looked at some of these other inflammatory issues that I think we often overlook, and one would be ankylosing spondylitis. This is most common. The ankle is actually the most commonly affected joint that's not in the exoskeleton. We'll see the ankle affected more in our HLA-B27 positive patients, and then our patients who present with juvenile ankylosing spondy rather than adult onset. If we're looking at psoriatic arthritis, the ankle is involved in about 30 to 40% of patients. It's more common in females, and then it's more common in patients who have that pitting disease in the nails. You can kind of see it there. We can move on. Also, not to forget about inflammatory bowel disease. Patients with Crohn's disease over UC are more likely to get ankle arthritis. Again, the typical one we think of is rheumatoid arthritis. It's rare to have ankle symptoms at presentation. It's more common in the established patient. And then looking into septic arthritis, we always think of bacterial infections. You're more likely to get bacterial infections in the knee, the hip, and then the ankle. These are typical streptococcal, staphylococcal, but of course, don't forget about the gonococcal diseases that can cause polyseptic arthritis in our patients. We don't typically think about viral septic arthritis. It's typically transient and it's not as destructive as the bacterial arthritis. We see this in our Hep B and C patients, HIV, and this chikungunya disease. This is a mosquito-borne virus that causes headaches, myalgias, joint pain, and swelling, and common in the Americas. And of course, we have our crystal arthritis. About 50% of patients who have gout will report some ankle arthritis. Much more common, of course, in the first MTP joint and the midfoot, but you could get ankle arthritis as well. And then the Charcot arthropathy. We all know this and love it. And our patients with peripheral neuropathy, I was a little surprised that it's only in around 0.1 to 0.9% of patients with who are diabetic. I don't know if that's broken down to if they've already gotten to neuropathy or how long they've been diabetic. The midfoot's the most common site, and if it involves the ankle, we often see subtalar joint disease as well. And then something that I often forget about is hemochromatosis. Patients who have hemochromatosis, anywhere from 30 to 60% of patients have ankle arthritis. If you have a patient with this, you want to look for multiple joints being affected, like the rheumatoid arthritis type patient. They tend to have arthritis in the larger weight-bearing joints. So the hip, the knee, and the ankle are the more common sites. And then in your imaging, you're going to see a more destructive pattern with cystic formation on the MRI. That's it for me.
Okay. Let me scroll down. I think that was an excellent recap because I often forget about the kind of outliers, right? The inflammatory bowel disease, the psoriatic arthritis patients. I just don't see as many of those. I feel like most of my ankle arthritis conversations are either like really nice and you're like, oh, I'm 67 and I just randomly got ankle arthritis idiopathically, or it's like I'm 30 and I had this terrible trauma, which the upside of that is that if you're the only foot and ankle surgeon at a level 1 trauma center, then you get all the post-traumatic ankle arthritis. The downside of that is that a lot of those people are really young.
Yes. Yeah, I feel like I most commonly lately have been seeing, post-traumatic ankle fractures, but then patients that will say, hey, I sprained my ankle such and such years ago, thought it was nothing, and then end up with asymmetric loading.
Yeah. I agree. Okay, hold on. Let me go back. So I thought this was a really interesting topic, and I was kind of glad that Dr. Prick assigned me this hour because I haven't spent a lot of time evaluating the biologics of ankle arthritis. And in residency, you spend a lot of time talking about knee and hip arthritis. And when you talk about the pathologies of those, as Dr. Alejandro had mentioned, like you feel like they should just transfer to the ankle, but then you realize at some point in residency you never talk about the ankle when you talk about the hip and the knee, and that's because it turns out they're wildly different. And so then outside of some cursory things like, oh, we don't do it, or it doesn't work, or it's not approved, I don't know that I've like really done a super deep dive into the biologics of ankle arthritis until making this talk. So that was a plus. I learned a lot, and now you can learn a lot too. I think the first thing to consider when we talk about it is that when we talk about ankle arthritis not being like hip and knee arthritis and talking about 70% of ankle arthritis being post-traumatic, is that the overall like cellular milieu of the ankle with post-traumatic arthritis is different than knee or hip arthritis. And so when we're talking about things that act differently, then you think, well, are these treatments that have been shown or have attempted to be shown to be beneficial in the knee and the hip, are they actually going to be beneficial in the ankle? So there's a number of things that you can do to make kind of biologics, right? So, and in narrowing this down to just ankle arthritis, then that kind of narrowed it down because there's a lot, right? I mean, if you just name these things and then think about all the applications you've heard of them being used in, there's no way like we could cover that in an hour at all. And I try to make this like a pretty manageable talk. So PRP, or platelet-rich plasma, we have probably all heard of, for good or for bad, right? Lots of people are doing it with or without appropriate indications, but lots of people are doing it. People are doing it in kind of like off-label sports medicine offices. People are doing it in orthopedic offices. And we'll get into how well it works for ankle arthritis. Bone marrow derived mesenchymal stem cells, adipose derived mesenchymal stem cells, and amnion derived mesenchymal stem cells all kind of fall into this big clump of mesenchymal stem cells, and then hyaluronic acid, which Dr. Wolf had also touched on as well. So what does literature say? Like many things that we don't have an answer to, right? So like, that's how I feel about bunions, right? Like, what does the literature say? I don't know. It says you can do anything at any time and it might work. But it says everything, right? If you want a paper to support what you want to do because you suddenly want to do more of X injection in your office, you can find a paper to say that. And it might not definitively say that, but it might say it's like non-inferior, or maybe it's like close enough to maybe being good, or maybe it buys your patient some time in modifying how symptomatic their ankle arthritis is. And then you can kind of justify doing that. But it's hard to find like some really great quality randomized controlled studies or just overall well done studies in general that we can then extrapolate out or just use and say like this will work for the ankle. I really tried, based on my previous comment, I really tried to not include any knee literature because again, it probably doesn't transfer over as well as we would like it to. And so we really need to be looking at studies of ankle arthritis to talk about treating ankle arthritis. So like Dr. Wolf had mentioned, hyaluronic acid, it's only labeled uses for the knee. So if your patient asks about it, they can probably pay for it if you have a patient population that is interested in doing so. But we'll get into the data, but you can't just submit it to the insurance, at least here in the United States, to get hyaluronic acid covered. But the general goal of this is that hyaluronic acid is in the synovial fluid, and at like the most basic level, it decreases in arthritis. And the idea is that you can increase this with an injection to try and supplement your native joint fluid with the hope being that this will decrease pain and inflammation. Increasing hyaluronic acid that is not made by your joint, turns out, is not nearly as great as your own joint making it. But for some people, particularly in the knee, they really swear by it, right? Like, people, and even the knee literature isn't that conclusive, but insurance pays for it. And people who come to your joints partners and see people, multiple times a year for their injections. Although I think insurance is, particularly in the US, becoming more rigorous about who they're approving these injections for and who they're covering. And there's definitely more financial risk than there used to be in doing them in your office now. But there was a study in 2013 where they did a systematic review looking at this, and they basically evaluated 4 randomized control trials, 1 comparative study, and 4 single-arm prospective studies, which gave them a total of about 350 patients. And when they did this, they looked at these studies here, and I kind of opened all these studies and looked at them individually. And again, they totally vary. Like, how many injections did you get? How good was your study? Was it a single injection? How long did you follow up for? And you could see in the follow-up column, which is in the middle, that overall the longest follow-up was 18 months, but most of them were 3 to 6 months. And 3 to 6 month injections are, really hard. Somebody might get better for 3 months, but it's hard to prove how different that makes your quality of life if you improve for only 3 months, unless, your daughter is getting married and improving for only 3 months is good enough for you, because after that you plan to do something else. But so these initial randomized control trials are at the top. Some of them were multiple injections. One of them was just 1. And then in the bottom, they looked kind of more at prospective studies. They did talk about adverse effects, but the adverse effects of the injections are the patient called and said it hurt. So none of them were exactly one said 17 out of 20 people said they had injection pain, and they reported 17 out of 20 adverse effects. But it turns out that's, probably not that relevant. If you stab somebody with a needle in their ankle, it probably hurts. So when you look at just the general summary of looking at hyaluronic acid in this paper or in this systematic review, overall, the randomized control trials favored getting some benefit from hyaluronic acid injections. Again, the benefits were overall fairly short-lived, and the follow-up was short, but they look okay. You're certainly not, they're not worse. Some patients are better, and some patients are better for a while in regards to their VAS or their FAOS pain scores. And they talk about that here. And so, you know, if somebody comes in and says, like, I really want this injection, you can tell them they might, probably, maybe will get better for some number of months. And some of these studies, right, this one, the randomized double blind, they did one single injection and then compared that to saline. And this was now, I don't know, 10 years ago, and the patients did not get better. And then the next study, which was also in this meta-analysis, they looked at 5 weekly injections, right, which, one, that's expensive. 2, you have to have patients come to your office 5 weeks in a row. And I think that's difficult to replicate for most people. But it showed that maybe these patients are getting some benefit. Somebody asked about PRP, so we should talk about it. And PRP is interesting, kind of like hyaluronic acid and kind of like stem cells, right? There's no actual data to say how much PRP actually has the most, but to say like what quantity you should be using, what the cellular concentration should be, what their goal is, right? And you can say like, I want this name commercial company to come to my office to do my, you know, PRP spin down. And they will tell you, you know, like ours generates this number of cells. But even if that's replicable from within a company, right, then there's no data that says like that company is right, right? They've just done their own research and decided like this seems to be reasonable. And so the downside to all of these is that even when you're comparing studies, again, like many studies, right, you're not comparing apples to apples. You're comparing outcome scores, which are largely being utilized fairly similarly in foot and ankle right now. There's a lot of FAOS in these studies and some like FADI scores, and you can compare those, but the studies themselves are like difficult to look across. So the idea of PRP, right, is that you can spin this down, you can draw somebody's blood in your office, you can spin it down, and that you will generate this high concentration of platelets. And as we all know, platelets have a lot of different effects, you know, the whole like increase VEGF, decrease IGF, and they can decrease the inflammation. And they can have an anabolic and analgesic effect at your joint, at your tendonitis. There is some pretty good data about PRP in Achilles tendinopathy. And I did know about that, but I had not tried any PRP for ankle arthritis before. So when looking at PRP, in a 2023 study in AJSM, they basically took 100 people and you either got PRP or saline, and you got 2 injections, like one initially and one at 6 weeks. What's interesting about that is that I have not seen a lot of PRP injections for tendinopathy that are 6 weeks apart, but here they did 6 weeks, and then people were randomized and they were actually followed for a year. And this was done in the Netherlands. And I think overall, like the study is pretty reasonable, right? They followed people, they did things, everybody had ankle arthritis, although they weren't allowed to take any NSAIDs. And there's a lot of stuff about PRP and NSAIDs and it being inhibitory to your PRP effect. One of the studies we'll talk about, they excluded you if you took NSAIDs, which is really a problem because I live off a steady diet of kombucha and NSAIDs. But here they included arthritis of all comers, as Dr. Alejandra talked about. It wasn't just osteoarthritis, and most of the other studies we will look at will just be osteoarthritis across Kellgren-Lawrence grades 3 and 4. But here they looked at it, and you can see on this chart that at baseline, 6 weeks, 12 weeks, there's no significant effect of getting PRP injections, unfortunately. And so they could not justify the use of PRP, although again, I mean, people are willing to pay for anything. So I'm sure people are still trying it. I've run into multiple people who've gotten PRP injections in their ankle before they came. But now I know something to tell them. There was another study that came out of Italy where they, about 10 years ago, they looked at people with PRP. I think everything about this study was actually pretty wild. Like, everybody had to be less than 65. They had to have Kellgren-Lawrence grade 3 or 4 arthritic change on their x-rays. They couldn't be taking NSAIDs, but you also had to have, quote, failed other treatments. but all the patients had been in physical therapy. Okay, great. There's actually, I think, very little data that PT is beneficial in ankle arthritis at all. And they had all previously had a hyaluronic acid injection, but more than 6 months ago. So they've previously all had it. And then 4 of them had a previous arthroscopy. So now you've gone to PT, you've had a scope in a quarter or no, 20% of the patients, you had a hyaluronic acid injection, and now we're telling you you still shouldn't have any surgery, you should have a PRP injection. So then they did this protocol, which was also wild, where they drew 450 cc's of blood and then they spun it down per person. So I'm guessing, like, I hope you're doing this in a hospital, because like I'm not drawing a pint of blood in my office. And then they gave 3 cc's of PRP that they made in a particular concentration every week for 4 weeks. And again, like, you could not take any NSAIDs this entire time and up to like 2 weeks after the last injection. So at no point were you allowed to do anything other than get your PRP. So, but they said that it worked, and they had really long follow-up, like some of the longest, right? Almost 18 months. So at 18 months, they show that patients have an improvement in their VAS and their disability index, right? That's what they show in these 2 graphs on the right. But interestingly, like half the patients are like, okay, that was okay. 35% said they were very satisfied, and 4% were like, yeah, this probably didn't work. Interestingly, of the 4 patients who didn't get any benefit, 1 went on to have an ankle fusion, 2 went on to like have another scope. Like, it's very interesting. At no point, like, were the other, like, 19 of the people did not go on to have any more definitive surgery for their ankle arthritis, which kind of seems wild, because at 18 months, if my patients were still complaining, I probably would have offered them surgery a long time ago. But since this is a talk on non-operative management, we're not, yes, or shit, they went somewhere else. But since this is a talk on non-operative management, we are going to, not talk more about where they may have gotten surgery or not gotten surgery. I think I actually learned the most in this talk on adipose-derived mesenchymal stem cells, because it's not easily encountered, at least in my office, and it's not that easily encountered in the US because it's not approved. So we'll, in this format, but it is approved in a different format. So stem cells themselves, right? Like, we all know about like the local stem cell clinics that are like running rampant in every town now. And you can go see like a regenerative medicine doctor, and they can offer you these stem cells, or these amniotic stem cells, or these bone marrow like injections. I mean, people are offering all sorts of things, again, without significant literature supporting them. And often, again, at least in the US, without insurance covering them. But you can like go see a regenerative medicine doctor, and they can offer you X or Y, including PRP and these things, and you can pay cash for them, and you can decide if you find them beneficial, right? I mean, obviously paying cash for things does make things a little bit more likely to work. I do think, going back to the ankle arthritis bracing, that my patients who actually like have had to like pay for some type of bracing on their own feel a little bit more invested in it than, let's say my workers' comp patients who have bracing covered, and that's not a definitive enough answer for this problem that happened to them when they were at work, right? I mean, so I think people's motivations can obviously vary widely, but mesenchymal stem cells, you can get them from all different places, right? We can harvest them from your bone marrow. We can harvest them from your adipose. None of us have an umbilical cord remaining, but people can get stem cells from umbilical cords and harvest those as well. I don't know anyone getting periosteal stem cells, but I suppose that is an option. And patellar fat pad is actually a commonplace. So there was a study in FAI like last year. Well, it wasn't a study, but it was a review by Sam Adams et al. And, this is certainly one of kind of his interests, are regenerative medicine and what's called orthoregeneration. And I think he kind of leads that in the US. And the idea here is that there's many applications of adipocyte derived mesenchymal stem cells in the foot and ankle. And in their paper, they talk about all the different ways you can use this, from hallux rigidus to talus OCDs, to Achilles tendinopathy, even plantar fasciitis. But the idea here is that your adipose-derived stem cells act on cell signaling, and they can then differentiate into multipotent stem cells, but they rapidly proliferate. So you can essentially harvest them, culture them overnight, and then they can, ideally differentiate into what you would like them to. And one of the things that they can differentiate into is that they have a lot of cartilage regeneration potential. And so this particular CD146 subset has this capacity for chondrocyte differentiation. And if you culture it with some other growth factors, you can actually generate type 2 collagen. And so it's thought that if you can modulate the inflammatory cascade and you can culture this and grow collagen, that you can actually improve somebody's arthritis, their tendonitis, their, any other kind of itises that we have, because you're making a less inflammatory response. The idea here is that you can harvest the fat. A majority of the fat harvest is done essentially through kind of like liposuction-like techniques. So for people who are doing this, I don't know if the surgeons are doing it. I would not say I consider myself proficient in liposuction. But if you are, then I guess you can do it yourself. I don't know, you probably get maybe a plastics colleague to help you, but you basically will harvest this, spin it down, you culture it overnight, and then you can generate this kind of like milieu of cells in a few cc's. There's like shaking involved, like there's a whole thing, and it takes a long time. It's like at least an overnight thing. But because there's not a lot of this approved, like this is like essentially, I think there's one more approved. This is called like Lipogerm device in the US to try and create these stem cell injections that we can use.
So Amanda, one of my partners was previously doing that, and most of the surgeons that I know that are doing this are actually harvesting it themselves. They said it's pretty simple to do, and then this is actually something that you do in the OR and then inject directly back, because at least in the US, you can't send it off, bring it back. There you have to have what's it called, minimal. I forget the term for it. You can't
Manipulation.
Thank you.
Yeah,
Yes,
manipulation.
Yeah, minimal manipulation. And so they are doing this in the OR at the same time as they're injecting it, because that's the only way that these types of things in the US at least can be approved.
All right. Well, then I am going to expand my skill set into liposuction, and I will be charging cash. I'm kidding, for the record. All right. So considerations of harvesting this, right, is that you can harvest white or brown fat. Interestingly, adults have very little brown fat, but also brown fat has a much lower concentration of multipotent stem cells. And they've looked at different areas, the same way we looked at harvesting like, bone marrow aspirate or doing autograft, right? Like, where are you getting the best quality of cells in order to supplement your fusion, right? So here, where are you getting the best quality of cells to create the like cellular milieu that you would like to inject? So in comparison to PRP, this is a little bit more labor intensive, right? As opposed to just being able to do it simply in your office. You do have to go to the OR, and then apparently you can just do this yourself. So foot and ankle studies exist on these 5 things for so far that I've seen for adipose derived mesenchymal stem cells. It doesn't mean that the studies are great or that they have good outcomes. It's just that these are where there is some data. Obviously, we're here to talk about ankle arthritis, so I'll kind of leave out the rest of them. I never would have considered getting a stem cell injection into my big toe, but you can do it. So from maybe a few years ago, there was a study where they looked at adding micronized adipose tissue, which is called MAT, into advanced post-traumatic osteoarthritis. And again, like post-traumatic osteoarthritis is the most common kind, right? And it's a lot easier if you make a study where you're looking at like one type of arthritis. And so some of these are that, which is a little bit helpful. And so again, grade 3 and 4, Kellgren Lawrence, they had 6 months of follow-up. And they excluded people with RA or people who had quote, profound mechanical malalignment, although I'm not really sure what, there wasn't like a number on profound malalignment. Someone said good morning to Yemen. So they here for their adipose, right? Just so you like are aware of like how much work this did take. I mean, it's not like it takes that long, right? But in order to harvest this, they would basically inject the solution, and then they would essentially like inject that, wait 15 minutes, then harvest it using liposuction. And then they use the same kit we showed you before. And then it reduces like the size of the adipose while like kind of like shaking them gently. And then they decided kind of, I don't know if it was arbitrary, but they picked 5 cc's of this to be injected into the ankle. They're saying that they used 10 to 15 cc's for the knee. And so they thought 5 would be like pretty reasonable for the ankle. So they harvested this and then injected into the ankle. Unfortunately, as you can see, patients did again have like a pretty good relief from like 6.6 to 4 on their VAS pain scale. But it never got rid of all of their pain, and it didn't change their daily activities. And so some good that come of it, right? You can look at the FAOS and you could say like, oh, well, overall they did do better and it was statistically significant. But unfortunately, their daily activities didn't change, and they kind of hypothesized in the paper that maybe it didn't change because your pain didn't go down enough for you to go back to stuff that you were actually interested in doing. Like you felt slightly better, but it wasn't actually enough to make like a qualitative difference in your quality of life. And then back much later, between 1 and 2 years, which I realize is kind of an arbitrary time frame, they were back at about a 5, right? And so how much did it help you to go from a 6.6 to a 5 as far as like your daily function? So other interesting things, they separated out their Kelvin-Lorentz 3s and 4s. There was not really a significant difference. The group 3s did better across the board, like they had higher numbers, but statistically comparing 3s and 4s to each other, like to themselves, I mean, they did not have a better improvement from one or the other. When you ask the patients on like a 5-point Likert scale, like how likely are you to do this again? Only 10% were very satisfied. Another 10% were very unsatisfied. And most people were kind of like somewhere in the middle, right? Like it was okay. It probably wasn't great. It's hard to know if they'd do it again. One of I think more like, this one's in international orthopedics, which I interestingly do not have access to. But they looked at this as well. They did evaluate people longer, and they collected an AOFAS, a FADI, and a VAS. And basically, again, they improved over the first year, worsened over the second year. They were not randomized, but they were prospective, which kind of shows you the same thing. For short term, maybe buy you a year, give you some additional time, they may totally be worth it for you. And the last study I'm going to talk about was where they looked at just a systematic review of injections across the board. This was published about, 5.5 years ago as a review article. And we'll finish with summarizing that. So they basically looked at these 27 studies. There is the most data on hyaluronic acid, which we kind of previously reviewed and looked at some of those studies. Corticosteroid, I kind of, left out as a mainstay of interesting science, but we all know that corticosteroid injections exist. PRP, there's like these few studies, and stem cells, there's only this one study that was published in around about 8 years ago. When we talk about hyaluronic acid, they looked at 19 trials. 11 of these were case series. They left out a couple that were for hemophilia, and one was for another cause that was like unrelated post-traumatic arthritis. And again, kind of summarize again, early improvements in pain, stiffness, function, and quality of life. The benefits were short for most studies. Some studied their patients for 12 to 18 months, and some did get some longer lasting relief. And their take overall was HA may be beneficial, right? It's certainly not harmful, and it may be helpful. When they looked at the 3 randomized controlled trials, that's a total of 109 patients, predominantly comparing this versus saline. And again, like 2 of those studies used the 5 injection series, which I put up that abstract before, and 1 did a single injection of Suparts. And again, they all trend towards like like maybe this is a little bit helpful. And this is looking at things over 6 weeks, 3 months, and 6 months. So maybe they're a little bit helpful. Again, there was very little risks. There were not a lot of complications, but you're not getting long-term relief from these. And then the one study that we talked about from 2015, they looked at a 30-month prospective evaluation. They interestingly evaluated walking distance. They didn't put a p-value on it, but everybody was able to walk more from baseline to 6 months to 30 months. Their FAOS score improved by 30 months by a statistically significant amount, and as did their WOMAC. There are no more studies to replicate this, but this is like the one study where we really looked at it that said who goes. So my conclusions are that the best data we have so far is in hyaluronic acid, but it's also the most data, right? We have way more studies in that than we have in anything else. Anything that you suggest injecting may be beneficial in the short term, but probably has an overall short-term relief, and it depends if that's good enough for your patients, right? And again, we're talking about in the United States, where you may have access to other options, such as, surgery in a reasonable time frame, or you're not waiting and trying to get you by. But these are all options. Medium long-term results, some of them, they look like they're beneficial, but in most studies, they're not even available. And like many things that we talk about, if we're going to try and compare things, we need actual better quality standardized randomized control trials, so we can compare the appropriate fruit to the appropriate fruit. So that is kind of the synopsis of what I learned about regenerative treatment in ankle arthritis. I like baking, so here are some things I've made, although I'm currently going to go fix a Schatzker 5 plateau soon, so there will be no baking today. And then this is Dr. Wolf's little nugget. And these are Dr. Alejandra's kids. And we all thank you for tuning in to the 4 a.m. lecture on ankle arthritis. And we are open to questions.
Sorry, my voice. That was a great talk on the use of biologics. I don't think I've seen a summary that concise about all of them. I do often have patients that will ask me, but once you tell them it's cash pay, most people back off and just want to try the steroid. I wonder, I do have a few patients who never want surgery that just keep coming back for steroid injections. And I wonder, since you get some short-term relief with HA, maybe they would do the same with that, but it'd be much more expensive. So curious if you did like a head-to-head study, it'd be interesting.
Yeah, I agree. I haven't actually even, I don't actually even know what the cost is of an HA injection. Like my office gives tons of them, so I guess I just ask my joints partners, what they're doing, and we could find out. But I mean, I think the volumes are different, and then it's hard to know if that extrapolates. And like, I highly doubt I can convince somebody to come back 5 weeks in a row to do it. But I mean, I guess if you really don't want surgery, it's certainly an option.
I think that one was the specific visco, like Suparts requires 5 times. So that was just probably the specific visco.
Yeah. And one of them just did a single shot of Suparts, and that was about the same. So who knows?
I mean, even like looking at PRP is pretty expensive. It's in our office now. My last office is around $800. Now it's $1,000 an injection. And some of the studies have them coming back weekly. Like, I wonder who you can get to pay for that.
Well, it's interesting because I've had multiple patients come to me and they've tried injections from alternative providers that are $10,000 and they don't get any relief from it. So people are willing to pay money to try not to have surgery. But I think this is really helpful to provide some data to guide them.
Yeah, the markup you see on these injections sometimes is wild.
Yeah. Wild. I think what's also, I don't know that this talk made me feel like warm and fuzzy about ankle arthritis, right? It's like, well, you can try this brace that you probably won't wear, and you can try this injection that like probably won't work. And you can like, otherwise just like, I don't know, get some Hoka rocker bottom shoes and try and walk it off for a while. And, like in the end, I guess like, I really just hope that you want surgery. But, so I don't know. I feel like there's, you know, some things that we see that have like, that are very manageable, like without surgery for longer term than ankle arthritis. But I think ankle arthritis is tough, right? I mean, you know, people,
well, I think part of the problem with ankle arthritis when we're talking about it in one grouping is that there's so many different types of ankle arthritis. And so it's tough to compare them. So we can say they have Kellgren-Lawrence 3 or 4, but do they have valgus? Are they varus? Do they have other things going on? Are they pes planovalgus? So I think, you know, it's tough to compare these. And when we're looking at studies, even though they have Kellgren-Lawrence 3 or 4, they're a very diverse group.
Totally. Yeah. I mean, some of the studies at least looked at like just post-traumatic OA, which I think is kind of like more helpful, but also like most of my post-traumatic OA patients again, like are on the younger side. So maybe like injections are not a bad idea because 2 years for them is like, you know, can get you closer to getting a total ankle maybe. And so maybe like buying you a year or two with some injections like is reasonable. Right. But I think it's hard. And I think people's cutoffs for how early they're doing like ankle replacements is changing. And I'm sure there are many, many hours left in the day to talk about ankle replacements. Although I know there were some talks last night about it. I'll have to tune in and watch them later. Are there any questions? I don't see any in the chat.
I don't see anything in the...
No questions that I'm seeing coming through, but that was a great session, guys, because we don't, you know, get a chance to hear the non-operative injectable side of things very often. And regenerative medicine is becoming a bigger and bigger thing. In the US, you can't manipulate the cells, but outside the US, you can manipulate. And there's some theories of that manipulation makes these cells more potent. So that's why you still see a lot of the athletes leave the US to get these things done, but that won't be allowed here in the US. And then when you talk about regenerative medicine, it's not just the stem cells, but it's a lot of these proteins, these exosomal injections, and all these other protein injections that are actually being done in the US under the table, and the data is still out there and experience is still out there, but we'll see. So I appreciate this session, guys. We're going to wrap up, and then we'll start in 2 minutes with the next one. Thanks, everybody.
Thank you so much. Thanks for putting this on.